These are the important references. Our objective was to derive a formula to predict cardiovascular events during a 10-year duration of time in SLE patients. We already have several such formulas for the general population, with the Framingham equation being the one most commonly used, but there are many others that have been developed in other countries. In fact, when we compare these newer equations, they usually are not better than the Framingham equation. The one that is talked about the most is the Reynolds risk equation, because it included high sensitivity CRP. The result of this change was that cardiovascular risk was increased in women, but decreased in men. I will let you draw your personal conclusion. In rheumatoid arthritis, the advice has been to multiply an existing risk equation by 1.5 to represent the increased cardiovascular risk of RA. I thought that we could do better than that in lupus because we could actually derive a formula using actual data. We know in the Hopkins lupus cohort that our patients have a 2.66-fold increased risk of cardiovascular events. We know that traditional cardiovascular risk factors do predict actual events and also predict the progression of subclinical atherosclerosis. For example, both smoking and hypertension are independent predictors of progression. Therefore, traditional cardiovascular risk factors must be in any lupus equation. Even after we adjust, though, for every single traditional cardiovascular risk, lupus patients still have a 2-fold increase in coronary calcium over controls. So obviously, lupus-specific factors must be in the formula as well. Should hsCRP be in the formula? In our cohort, it is not predictive of later myocardial infarction or angina. Instead, the major associates of a high hsCRP are obesity and ethnicity, with lupus activity only having a small role. Our study design was to use the data from the Hopkins lupus cohort. The first 2 years of follow-up were used to assess the risk factors, and then the incident cardiovascular events were ascertained. This was our definition of cardiovascular events. Our statistical method was to use Cox proportional hazards models. Our patients were mostly female, both Caucasian and African American, ages between 20 to 60, and a variable duration of follow-up. We observed 109 incident cardiovascular events, predominantly strokes, but also myocardial infarction, angina, and claudication. These are our model results. For each of the risk factors, we converted the hazard ratio to a simple integer score to simplify the calculation of the formula. You will see at the bottom the 3 lupus-specific factors: a SLE day of 2 or more, lupus anticoagulant, or low mean C3. We can calculate the 10-year risk using this exponential equation. For example, in a male lupus patient, age 50, with a BMI of 23 and a high systolic blood pressure, his risk over the next 10 years would be 7%. Let's look at a very simplified way of doing this, because I don't do exponential equations in my head. Let's look at the integer score. This man, because he's 50, will get 2 points for age, 2 points for being a man, 4 points for his BMI, and 3 points for his systolic blood pressure. So when you employ this in your own clinic, you'll count up the integers using this slide. And then on the next slide, you see the slide rule. Because he has a score of 11, we look just below, and his percent risk is 6.1. You see that this agrees very well with doing the actual exponential equation, where it was 7%. Let's look at some common examples. So if a woman with lupus is age 50, has a BMI of 23, has a high blood pressure, but a normal cholesterol, her risk using the lupus equation is about 4.3%, agreeing quite well with the Framingham equation. The patient just below, we add a high cholesterol, the risk goes up, and it's equal with the SLE formula and the Framingham. Now, though, let's add the lupus-specific factors. So the patient below, we add the lupus anticoagulant, and now you see her 10-year risk is double Framingham. The patient below, we added high disease activity, again, double the risk of Framingham. And finally, in the last patient, we add low complement, double the risk of Framingham. Now, I freely acknowledge limitations of the Hopkins lupus cohort. We do not do HDL and LDL every 3 months, so I could not use these subparts of the lipid profile in the formula. Obviously, this represents one city, Baltimore, and one provider. It needs to be independently validated in other cohorts. And it does reflect 1988 onwards, so it's possible that 2013 might differ somewhat. In conclusion, using cohort data derived every 3 months, I've shown you a data-driven cardiovascular risk equation that includes 3 SLE factors: SLE, lupus anticoagulant, and low C3. But it also includes 5 traditional cardiovascular risk factors: blood pressure, cholesterol, smoking, diabetes, and the body mass index. As always, we are very grateful to our granting agency, NIH, and we certainly hope Congress will do something about the sequester of NIH funding. Thank you very much.
Okay, the paper by Dr. Petri and Major is ready for discussion. Any questions, please come to the podium, identify yourself, and say where you are coming from.
Eurowitz, Toronto. Michelle, thank you very much. I know all of us are trying to identify those patients at higher risk so that we can target them for treatment. And we've had the same issue. We've taken an approach a little bit more simple than yours. We recognize that the Framingham score is universally available and often available on algorithms, on sheets, and on table handouts. We looked at the Framingham score and assessed different multiples of the Framingham score at 1, 1.5, 2, 2.5, and 3. We found if you multiply the Framingham score by 2, just take the Framingham score and multiply each by 2, you end up with an identified risk in the moderate to high group of 15%, as opposed in the Framingham score, you end up with about 2%. So we're identifying 13% more people And those are the ones that we're targeting as high-risk people. And it's very simple. Just multiply Framingham by 2.
That would be very similar to what was recommended in rheumatoid arthritis, to multiply Framingham by 1.5. I hope no one, though, thought that what I presented would be that difficult to use in the clinic. Remember, you just need that one slide of the integers and the other slide of the slide rule. And I'll be happy to send it to anyone who wants to use it. One difference in our approach is that it's individualized and data-driven. So, for example, if you had the unlucky patient with SLE, lupus anticoagulant, and low complement, their score would be much more than a doubling of Framingham. I hope it will help you to individualize to the patient who has multiple combinations of these integers.
Meenakshi Jolly from Chicago. That was a good presentation. Thank you. My question is that complement reduction is already part of SLE, so why would we want to include that into the model again?
You're absolutely correct. Low complement is part of the SLE, but it's only 2 points of the SLE. So people can come to a SLE score of more than 2 in many different ways. In our Cox proportional hazards analysis, the low complement and the SLE were actually independent.
Small question, please. Dr. Tazi from Morocco. Did not see the corticosteroids in your evaluation, risk evaluation. Does it mean that it's difficult to add them or it's not important?
Corticosteroids are important. We actually showed that a prednisone dose of 10 milligrams or higher more than doubles the risk of a cardiovascular event. The corticosteroids also influence so many of the traditional cardiovascular risk factors, such as hypertension, diabetes, weight, and hyperlipidemia.